Hello, my name is James Inciardi, and this is my case study on shock. In this study, we'll be looking at a patient who went into shock as a result of coronavirus infection. The case study was published in the New England Journal. The reference information is there on the screen. So without further ado, let's get to work. So here are the objectives for the lecture. By the end of this lecture, you should be able to summarize the disease process of COVID-19, summarize the cardiac implications of COVID-19 patients, and describe cytokine storm and its relation to COVID-19. Okay, so here's our patient, Karina V. I just couldn't resist making that name up in light of, whatever. Anyway, Karina is a 44-year-old female who immigrated to the United States from Peru 20 years ago, works as a janitor. She's married with 2 teenage children. Now, as I told you, she's going to get coronavirus, and let's just make things simple and say her medical history is largely non-contributory. But one thing to note is that she does not have a history of hypertension. So that's important, and I'm going to tell you why a little bit later. Okay, so onset of symptoms, as you can see here, she most likely caught coronavirus from her husband, who had a mild case, but she came down with a pretty extreme case. They suspected coronavirus and tried to manage her as an outpatient, but that didn't work out. Just 8 days after her first symptoms, she called 911 and was brought by ambulance to the hospital. Here is her presentation at the ER. As you can see, although the coronavirus is known mostly for its respiratory implications, she has a very low blood pressure in the ER. And if I can just pause the storyline for a minute, we can see that she is in decompensated shock. The blood pressure is low and the heart is trying to make up for it, and that's why the heart rate is going pretty fast right now. So the patient required intubation 3 hours after admission to the ER because they weren't able to maintain a blood pressure in spite of the use of pressors. You can see that her heart rate increased from 103 to 140, and her blood pressure is unstable, dropping below 70 systolic. So we're going to step back from the case study for a little bit, just kind of pause for a little bit, and do a little review about the coronavirus. Here's the life cycle of the coronavirus. This chart summarizes the effects of coronavirus on the lungs and pulmonary vasculature. Coronavirus cycle starts with the interaction with the angiotensin-converting enzyme 2 receptor from the host cells. Several researchers have identified that the ACE2 receptor is the entry receptor for COVID-19. It infects cells in the upper and lower respiratory tract, especially nasal ciliated and alveolar epithelial cells. One reason why coronavirus is so deadly in people who are older is because when you're older, you are more likely to have hypertension. So if you can remember how the renin-angiotensin-aldosterone system works, then you can probably see the connection. And that's why it's important that Karina didn't have hypertension. So when the virus gets into the host cells, the viral RNA genome is then translated. The proteins and RNA are packaged into progeny virons being released to infect more cells. The coronavirus-related disease results in a huge cytokine outburst. Reactive oxygen species are key signaling molecules that play an important role in the progression of inflammatory disorders, resulting in oxidative stress, mitochondrial dysfunction, and DNA damage. In addition to the parenchymal abnormalities, disseminated intravascular coagulations, endothelial dysfunction, and impaired hypoxic pulmonary vasoconstriction ultimately generate pulmonary microthrombi, VQ mismatch, and hypoxemia. Interestingly, you know how the lungs will decrease perfusion to certain parts of the lung that are not getting oxygen, right? Well, somehow the coronavirus is able to defeat that defense mechanism. It might be due to increased nitric oxide production in the setting of coronavirus. Anyway, the result is a greater degree of shunt from the lungs. Okay, and this is some pictures of Karina's lungs. And the only reason I put this in there is because I thought Dr. Coyle might want to look at these pictures at the end of the presentation and tell us about what he sees here. I'll have to admit I'm not very good at looking at these, so we're just going to have to leave that for him. All right. Next slide. Now, speaking of Karina, she was eventually diagnosed with COVID-19 infection, complicated by severe acute inflammatory cardiomyopathy and cardiogenic shock. The cause of cardiac damage in COVID-19 is still not known. You can see the suspects there according to the New England Journal, but they think that it probably has to do with a combination of all three: the stress, cardiomyopathy, the cytokine storm, and the myocarditis with or without pericarditis. Okay. Now, what we're seeing in Karina is an acute cardiac injury. So she's in cardiogenic shock. The heart is not able to pump out enough blood to preserve homeostasis. Because of COVID-19, we're seeing decreased ejection fraction. This process is very stressful on the right ventricle, and the right ventricle is very sensitive to low oxygen. In fact, there was a study I read, and I couldn't find where I read this, but I did read that the right heart failure was a common cause of death in COVID-19 patients. Okay, next let's look at I've talked about the cytokine storm a couple of times, and we're going to look at it a little bit more in depth. Cytokines are part of the immune response to COVID-19. In a cytokine storm, the cytokines are mass-produced. Normally, when the virus is beaten, the cytokines are deactivated, but in COVID-19, the cytokines continue to be produced, and there's no brakes for the response. Along with these cytokines, there are toxic compounds that the body produces. This causes a lot of organ damage as a result of cytokine production and toxic compounds. If you remember that your typical ARDS case has three forms of damage: volutrauma, electrauma, and biotrauma. And that biotrauma is what we're dealing with here. So here's how the cytokine storm happens along with the body's normal immune response. First, the virus enters alveolar epithelial cells. It can enter through a number of receptors, but it likes the angiotensin-converting enzyme 2 receptor the best. The ACE2 receptor is seen in the lungs, but also in the intestines, kidneys, thyroid, testes, adipose tissue, and the heart, which is probably part of the reason why Karina is in cardiogenic shock right now. The next step we have is the pulmonary recruitment of macrophages and dendritic cells in response to chemokine and cytokine release. This is a normal response, but it will eventually spin out of control and become the cytokine storm. The third step, we see direct viral infection of pulmonary macrophages and dendritic cells, causing expression of several pro-inflammatory cytokines and chemokines. And then step 4, we have the dendritic cells phagocytize virus in the lungs, migrate to secondary lymphoid organs and activate antigen-specific T cells, which travel to the lungs and destroy virally infected alveolar cells. That's good, but we also have the cytokine storm. That's not so good. Okay, so back to the case study. We're going into management, what they did for Karina here. In this patient, they really threw everything they had at her. They started with ECMO, but eventually they actually had better results with a BiVAD device. That's ventricular assist device on the left and right ventricles. And that increased Karina's ventricular ejection fraction. They decannulated the ECMO, and then, this is the line they use, I love this line, quote, "In the absence of clear data from randomized control trials of antiviral or anti-inflammatory therapies for the treatment of COVID-19 at the time, we provided general supportive care for this patient." In other words, they really didn't know what they were doing, but you really can't blame them. I mean, these are pretty interesting times we're in, and coronavirus is a new one for everybody. So we can't really blame them too much. But anyway, after 6 days, the heart had recovered enough that they were able to remove the BIVAD devices and eventually tapered off the inotropes. So here's how the discharge went. She went to a rehab facility. Her ejection fraction was still only 47%. I would have liked to have known if her heart ever regained its ejection fraction. It said in the telephone interview in a follow-up appointment 2 weeks later that she had no symptoms, so I guess it means her heart did recover, but did it recover fully? I still kind of wonder about that. And then she was readmitted to psychiatric emergency services, and she was readmitted after her blood alcohol level was exceeded known survivable limits, which happened after she got the hospital bill. Now she's getting another hospital bill from the PES unit, so she tried to flee the country to avoid paying the bill. The plane crashed and she was readmitted again, so she's now getting a third hospital bill with these new charges. No, that last one, this slide is just a joke. I'm just kidding about that. Here are my references, and thank you for paying attention, and I hope you learned something. And next, I'm just going to put on a slide with Karina's radiology stuff, so that maybe Dr. Coyle can tell us what he sees. Thank you very much.